Hello. Welcome
Hi.
to Kindly Neurodivergent with Kay. This show is to spend quality time with each other, kindly discussing the similarities and wide range of differences we experience. The experiences we discuss on this show are for educational purposes only. Please do not substitute for professional medical advice, diagnosis, or treatment. Before we begin, I respectfully request that if you witness any pauses during this show, please continue watching. I'm composing a spontaneous comment or question, someone's processing their thoughts, in addition to repeating something that was unintelligible or misunderstood. It is natural discourse, and we can choose not to say anything while this is occurring. Today I have Dr. Mitchell with me. She is here with me to discuss the connection between airway health and sensory needs. Dr. Mitchell is a doctor of occupational therapy recognized for her work in sensory processing, child development, eating and swallowing disorders, and myofunctional therapy. She integrates sensory-motor strategies and airway health to address complex neurological diagnoses such as ADHD and ASD and airway challenges at every age. As the visionary founder of Airway LA, Dr. Mary Ellie specializes in sensory processing, motor skill development, eating and swallowing intervention, nutritional support, and sleep training, offering holistic, client-centered care designed to transform health and well-being. Welcome, Dr. Mitchell.
Thanks for having me.
Please introduce yourself.
Yeah, so I'm Dr. Marielle Mitchell, and that was a great intro. And I am a doctor of occupational therapist based in Los Angeles. So I'm the founder and director of Therapy LA, where we specialize in really taking an integrative and more holistic approach to helping children with all sorts of different diagnoses. And we really take a focus and with looking at the lens of airway health, which means looking at the way children breathe and they sleep and how that impacts their nervous system and their sleep, most importantly, one of the most important things in my opinion, and how that can impact their behavior and their ability to process sensory information and then have the appropriate motor responses, whether those are physical motor responses or cognitive responses of motor planning. So that's kind of what we do. We also do a lot of feeding and swallowing. That's a specialty that I have that is part of my practice and kind of got me into the airway world. And so that's what I do. And I have a team here. So I have a team of therapists and we've got a great clinic here and we see kids in the clinic and at schools in LA.
I am the founder host of Kindly Neurodivergent with Kay. I am the office manager at Silver Speech, in addition to a co-host of the Inside Scoop of Living with Cerebral Palsy. I am a co-author of Living with Cerebral Palsy, led by Kyle Scott. I am a member of the State Student Disability Council as a student of State Community College. I am the communication assistant and a dedicated member of many committees for my therapeutic horseback riding program. As you see, I am a happy, motivated, and active, vibrant female with cerebral palsy and epilepsy who defied the odds.
Very
What
true.
is sensory processing?
What is sensory processing? Yes. So sensory processing is this process that we all have that we go through on a daily basis 24/7, and it is the way that your nervous system interprets information from the world through your senses. And so you have different sensory systems. So you have the obvious ones: vision, smell, you have hearing, you have taste, and things like that. But some of the more impactful ones in my opinion, well, vision's really important, but the way in which you feel your world and how you process touch and pressure and movement are really important. And so that's your vestibular system and your proprioceptive system and your tactile system. And so the way in which that you interpret that data that sensory input allows you to either integrate that or not integrate that. And if you have a challenge with sensory integration, then you're going to have a challenge with processing that information and having the appropriate output, whether that output is an actual motor response of judging and seeing how high a step might be and seeing how high you need to lift your foot and feeling that single limb balance as you do that, or walking into a room and knowing that you have to clean your room, but you have to organize and sequence the steps of where to start. Do you make your bed? Do you get your dirty clothes first? Do you start the laundry first? And does that make sense to do something and optimize your time and have that going while you clean your room? There's a lot of ways in which I call that cognitive, like motor planning in a way. And that's something that is really important for our day-to-day function as humans. And when you aren't integrated, it's really hard to be regulated and it's really hard to be coordinated, whether it's physical or cognitive coordination. So, mhm.
How did you come to the realization that your clients needed more than the typical occupational therapy treatment for sensory?
Yeah, that's a great question. So, sensory integration was like my first love. I went to USC and Jane Eyres and Dr. Anna Blanche, and I was lucky to be taught by a lot of the people who are some of the founders of this science and really have propelled it to the success that it's seen. And so I really was very ingrained in that world and still am. And I there is definitely a place for it. What I noticed though is that a lot of my kids would plateau or they would kind of not make a lot of the progress that I was expecting, or that a lot of the sensory input that I was providing with them wasn't sustaining the state of regulation that I was expecting or hoping that it would. And I wouldn't really, the outcomes were short-lived. And a lot of the skill acquisition was being lost at times. And when I started to have kids who had undiagnosed airway issues before I even got into the airway world, and I started kind of coming into my sphere more, tonsils, adenoids, allergies, things like that. And I would see that they would like have these procedures or dental expansion or things like that. And these kids would truly, everything that I was working on in their OT would start to stick more. It would stick, it would last, they would be sleeping better, they'd be regulated. I wouldn't even have to really regulate them anymore. Their goals would move a lot faster and they would be discharged, which was amazing. Some kids, I feel like they're working on sensory their whole lives. And when I started to kind of really dig deep, and then I went into feeding. And when I started having kids who went into feeding and they had orthodontic intervention, and then I would see them 6 months later and I didn't have to work on half of what I had to work on before because the teeth started just aligning and chomping and chewing and doing as they should, I was kind of like, there's something here. So then I really dove deep into the world of swallowing and orofacial myofunctional therapy, which really kind of made me nerd out on anatomy of the mouth and the more medical, I would say, side of things with my SWC. And that really changed my perspective on it not just always being sensory based and really honoring the principles of anatomy and physiology with these body parts and the dental side of things, truly.
I wish sensory integration was talked with cerebral palsy more than just motor.
Yeah, I know. Yeah, I think I agree with you on that one. And I think there's so many things that it could for the CP population in that sense, that there's so many things that people could kind of help with just in general with like regulation and like just overall like easing the ability for the nervous system to function and not just from a motor perspective, because I think people get stuck on the motor lens a lot of the time, right? Yeah. I think yeah.
Should people snore?
No. So people shouldn't snore. So people think snoring can be really cute. And if you're sick, it's like a thing you can snore then because you have a blocked airway and things like that. But snoring is never normal. Snoring is telling us that there's an obstruction in the airway in some part, whether it's like in the nasopharynx area, it's the soft palate, whether it's tongue placement, whether it's all the above. The airway architecture of the airway is something that's really important. And when it's like, would you want a house that just like shakes all the time? I don't think so, right? So we don't want an airway that's shaking and vibrating and not sturdy. And because for lots of reasons, well, most importantly, it impacts the quality of your sleep, but it also impacts the ability for you to get the appropriate amount of like nitric oxide and oxygen ratio to keep that carbon dioxide. All three of those gases have to be in a good ratio for your body to use it efficiently and appropriately. And when you are sacrificing that, it's truly impacting you physiologically and will eventually start to impact you neurologically with your brain function.
What's the difference between sleep disordered breathing, cranial nerve dysfunction, and facial myofunctional issue?
So sleep disordered breathing is a set of characteristics, and I like to call them like the annoying little like cousin of obstructive sleep apnea. That's how I like to see it. Sleep disordered breathing is like you're kind of on a fast track to getting obstructive sleep apnea further down the line, and then I think people kind of start to realize what it really is. So sleep disordered breathing, it has like a lot of the characteristics. I have an Instagram post about this, and then the acronym I made is called like bad resting, but it starts with like open mouth posture, halitosis, which is bad breath, breathing stopping, kind of also like presenting as like having like apneic episodes. So when people kind of or they gasp for breathing, that's you're on your way to having obstructive sleep apnea, or you might already have it and you just haven't gotten diagnosed with it. People grinding their teeth is also another sign of that. Tossing and turning, frequent awakenings at night. Bedwetting is a big one that people don't realize. And there's a lot of things about bedwetting with primitive reflexes and interoception and all those things too, which absolutely could be true for the case. I just come from a lens of there might be something physiological, and like if that's the issue, we don't want to address it neurologically. And that's kind of where I always kind of am always navigating between that line and jumping back and forth a lot of the time. And so that's something that I think people need to also realize with potty training, that if you have a child that's like not sleeping well and bedwetting, that's something to kind of look into. And sleep disordered breathing is basically you're having a really hard time breathing while you're sleeping. And so your sleep is no longer restorative. And that's going to impact your ability to regulate yourself, to all of the like the frontal cortex. That's the part of the brain that's responsible for impulse control, attention, memory, self-regulation, emotional regulation, organization behavior, all of those higher executive functioning skills, those invisible skills. It's kind of like hair, right? Like, do we need hair? We need it, but like, can you live without hair? Yeah. So when people have malnutrition, their hair falls out, right? When people get poor quality sleep, your executive functioning skills go. That's just what, do you need those to be alive? Not really. You need them to like have different levels of function and things like that, but it's really not something that is absolutely necessary. And so the brain's kind of like, well, I don't have enough oxygen for that. I don't have enough nitric oxide, so I'm just gonna go, I can't. And so sleep disordered breathing can really affect that. And so that's kind of what sleep disordered breathing is. And there's lots of different characteristics for that. Lack of cranial nerve integration. So your cranial nerves are basically a set of like nerves that you have. I like to refer to them as the electrical switchboard of your nervous system. And when they don't function correctly, that can really impact what they're supposed to be doing. Some of them have sensory perception roles. Some of them are in charge of your fight or flight. Some of them are in charge of your motor skills of your face and then your tongue and your jaw and things like that. And when those don't operate well, then you're going to have deficits in motor function in these specific regions, right? And if you have anatomy that might not be letting like the conduction of that nerve happening because you have a compression somewhere, that's something that needs to be looked at, right? Just like if someone's holding the foot on holding their foot on like a hose, that can impact the ability for the water to shoot out. It's kind of the same thing. And so you want to I like to say like activate, integrate, coordinate. And that's kind of what you do with like the sensory systems and with the nerves, and you stimulate it, activate it, integrate it, coordinate it. That's kind of what one of my mottos is. And then I think the last part you asked about is an orofacial myofunctional disorder. Is that what you said? Yes, correct. Okay. So orofacial, myo is muscle, and the function of these muscles. So orofacial myofunctional therapy really focuses on, most importantly, the function and the ability of the muscles of the tongue to work appropriately and to be able to sustain like tongue to palate contact and be able to tongue to palate contact. Close, yep, getting there. And with the lip seal. and facilitate nasal breathing. You can also work on chewing and you can work on the first phase of the swallow, but that's kind of where it ends for that profession. You don't go into phases 2, 3, or 4. That's not something that's more like speech, or like someone like me as an OT with an SWC would do that. So like we can look at like modified barium swallows, and I can at least with those, but you had one of those? Yeah, yeah. They're, I don't know if they, all of the things with that taste very good, but yeah.
I have dysphagia.
Oh, you had dysphagia. Yeah. And so dysphagia can impact your ability to swallow appropriately, right? And so yeah, and so that can happen at any like step of the swallow. And so that can, sometimes cause challenges or safety concerns and things like that. There might be dietary changes depending on what goes on. And some people do really okay with it, and they can function with, as long as they know where their abilities are with their skill level, and they can modify their diet appropriately. So myofunctional therapy doesn't necessarily address that, but it works on really honoring the principles of anatomy and physiology of the mouth, which I really appreciate, because I feel like a lot
Smaller
of people,
bites.
smaller palates, is that what you said?
Smaller bites.
Smaller bites. Got it. Yeah, good. See, you've got a good modification. It works for you, right? I love that. Yeah. Yeah, those are one of the modifications. And, my grandma's in the hospital, and she's doing fine now, but like one of the things they always check in the hospital is like, can they take their medications orally? And they always are precautious about that. And it's the applesauce test and checking all those things, right? And like thicken liquids, and how are we going to do those things? Yeah. And then building from there. And can this person feel this food and trigger their swallow fast enough so they don't, that's the most important part. Yeah. So that's kind of the more medical side of the feeding stuff that I do if I do that. But myofunctional therapy doesn't focus on that. But in my opinion, myofunctional therapy is almost a place a lot of people should start. And that's kind of a really like, that opinion can get a lot of pushback, because it's still kind of, people are like, well, like it's not taught in like all the speech schools yet and stuff like that. But when you really sit back and think about it, if the anatomy is not having the contact that it needs, like the body needs to feel itself. And if things aren't aligned, and none of us are, in perfect alignment, I'm very aware of that. But if your teeth don't touch, and your bite is really, you have a big open bite, or you have a big overbite or underbite, and there's a lack of connection on the teeth and the nerves and the way everything's supposed to work, it's really hard to get someone to want to choose something, because it's almost like on a subconscious level, the brain's like, I don't even know if like I can do this. And I've seen it time and time again where we start myo, and then I send out for ortho or dental, and we get the bite in better alignment. And the kid comes back eating 50% more than they were already eating, because everything kind of just fell into place. And then I still desensitize, and then I still, activate and integrate and coordinate and work on the oral motor skills and work on those things and broaden the horizons of like what that child's eating and stuff. But when the anatomy actually starts to fall into place, and that's really easy for me to say that, like a lot of my kids on the spectrum might not tolerate, orthodontics really easily, but the long game plan in our clinic is most of our kids enter into some type of appliance or dental ortho appliance if it's appropriate, and we
Can you
desensitize.
determine what specialists you refer to?
Yeah, so I look at the mouth. I look at the mouth and I see what's the alignment of the jaw. I look at craniofacial structure. So I look at this skull is something that I kind of always have in the back of my mind, right? So I can, at this point in time, like look and analyze people's facial structures, and I can kind of see behind the skin, what does the bone look like and what's happening there. And what happens is that your tongue is kind of like the stilts for the house around that's built, which is in your face, and also most importantly for your airway. And so when your tongue isn't there to support everything, things start to kind of collapse and move around from that. And so you'll see high vaulted narrow palates, you'll see eyes that kind of turn down sometimes, you'll see mid-face deficiency with like a lack of cheek definition or retrognathic jaws. Then I open the mouth and I see, do I see a blocked airway, like a Mallampati score? So I have an Instagram post about this too, where I'll look in a mouth and like, of course, if I see giant tonsils, like that's an issue, but his jaw fell off, sorry.
Why do tonsils get big?
It's a really good question. So tonsils get big because there's lots of different reasons. So it's an inflammatory response, right? And your tonsils are part of your lymphatic system. A lot of the cases in my clinic that I see is that these children have been breathing through their mouth for a long time, and they are, because of that, they're not using the filtration system in their nose, right? So you have filters in your nose here. And so when you mouth breathe, you're ingesting all of the things in the air. Think about it. So viruses, bacterial load, dead skin cells, dust in Los Angeles right now, it's asbestos, old mold, like all that stuff in the air is, you eat that. You're literally eating that. Over time, your tonsils and adenoids weren't meant to like handle that type of an insult. And so they become hypertrophic, they become inflamed as a result from that. And essentially it's like like for my, I like to say like a plumbing system, like once it gets clogged, it's kind of like it can't really pump and dump anymore on its own. And you can try meds and things like that, but over time, like the best thing is to get the person to breathe through their nose. But if things get blocked, airflow can't happen any other way. And so it's almost this like unfortunate vicious cycle that perpetuates this breathing pattern that got them there in the first place a lot of the time. And that can really impact the ability for someone to not mouth breathe, and then they kind of have to. And what also happens is that if you have an airway that's already kind of more narrow, like let's say you open your mouth and your soft palate's really dropped, and then you have enlarged tonsils. Now, like it's kind of like the tonsils are trying to add like more square footage on a house when the lot doesn't have any room, right? And it's truly architecture back there, but you're at the mercy of soft tissue. That's what people need to understand. There's no bone, there's no tibia, there's no radius, like there's no like hard bone. You're at the mercy of the cervical spine, which is these super funky, amazing bones, but they're kind of wobbly. You have more range here than you do in most parts. And the fragility of your airway is at the mercy of what your tongue is doing that supports all the soft tissue around, and your jaw, which we all know the jaw can get unstable because people have TMJ, right? You have TMJ too. Yeah. Yeah. TMJ is
Yeah.
the whole thing. Yeah.
How does the tongue impact sleep?
Great question. So the tongue impacts sleep because if the tongue is not in the right place, so I like to call the tongue the core. Like if, as an analogy, if when you stand up with really good posture, you're activating your core and your back extensors, right? I'm sitting up nice and tall, my core is on, my back's on, right? Your tongue is the same thing for your airway and for the quality of your breathing. So when my tongue is deactivated and down, it makes me mouth breathe. Okay. When I mouth breathe, what happens is that I go into a state of fight or flight. That's just how it works. It's the rules of the game. When you mouth breathe, you are essentially putting in your nervous system into a bigger state of fight or flight, which makes your sleep lighter and makes it harder for you to go into those more healing brain waves like delta, theta. I'm not like a sleep expert, but that's kind of generally, you want to like have different cycles of sleep and you want to have these more nourishing states of sleep. But if you are essentially mouth breathing, that's not going to happen because your nervous system's dysregulated at baseline. In addition to that, if you are not mouth breathing and your mouth is closed, but your tongue is still down, it's likely going to drop. It's going to drop into your airway like this, okay? Because it's not suctioned. It's going to drop into your airway. And so your brainstem is going to be like, I can't breathe, human, you can't breathe, like do something, thrash around, move around a lot. And you're going to have restless sleep because you're moving all night, right? Or you're going to grind or clench to stabilize. Yeah. And so it impacts. So think about all of those motor functions happening at night when you should be like, not you, but like the person should be comatose, dead asleep. You want good sleep. You want to be like thinking the person's almost not breathing. That's really good sleep, right? Someone's thrashing around. You can hear them breathing. They're talking in their sleep a lot. They're having really vivid dreams. That's a sign that that nervous system's actually not going super deep. And there's likely some type of airway issue. And I never want to be an alarmist, but this is so much more common than people think. And if you have any type of diagnosis that's neurological or psychological, like anxiety or something like that, it's going to exacerbate that because now you have a biological factor that's not being met. It's kind of like not having enough fats in your diet. Your brain doesn't have the fuel, right? You're not eating enough protein. You don't have all the amino acid chain. How can you secrete neurotransmitters? Like there's biological things that exacerbate neurological conditions. Like kids when they go for with seizures, right? You know, and if they go keto, some kids have really amazing results because they reduced inflammation, right? Did you try that?
No.
No. Okay. Well, some kids. So I worked at a place where it was just it was strictly neuro, and we saw really amazing results that when kids went keto, and it's because you're limiting the inflammation. And when you have this ability, and you're giving the brain so much fat and like protein and amino acids, it can conduct. It's electricity, right?
Mm.
You got to fuel it, and sleep. I personally and professionally really believe we're just on the precipice of understanding sleep. I think in 50 years, people are going to be like, oh my God, like sleep is one of the biggest things that humans need. And
What roles does sleep play?
I think sleep does so much more than we even realize. So, first off, one of my favorite facts about sleep is I don't know if you know, do you know what like the glymphatic system is? Have you heard of the glymphatic system? It's a little bit. Okay,
Mm.
maybe. Okay. So a lot of people don't know about it because it was only like discovered not that long ago. But so you have your lymphatic system, which most people know what that is, and like gua shas and all of the beauty things that people use. Like the lymphatic system is like the hot term now, and everyone's like shaving off your waist with a like lymphatic massage. It works because you're pumping and dumping and draining, right? And your tonsils and adenoids are part of that system. But your glymphatic system is the lymphatic system of your nervous system, okay? And your mouth, your tongue is essentially a pumping mechanism for that system to activate at night and have go through at least 3 cycles. When people do like osteopathy or craniosacral work, things like that, they are helping the glymphatic system also work. And so they're getting what happens is that you have all of these neurotoxins that develop through all the exposure of all the things we ingest and breathe and eat. And we live in a toxic world. It is what it is. But if you don't sleep well, your glymphatic system doesn't get activated. And so think about a lot of our kids with like ASD and they have like chronic inflammation. And then on top of it, they're not sleeping and they have inflammatory. It can be really overwhelming to like sit back and look at it, right? And I'm not trying to like fear monger or anything like that. It's just facts. But when people start to actually dial in their sleep and get to sleep better, you actually heal. Like your body's healing at night. Even when you're sick, that's why you sleep and you're so tired. Your body's trying to heal. And so, and then, I mean, I'm a big sleep proponent. I've always been a big sleep person. My family's always been a big, oh, she's sleeping, like be quiet in the house. So I was raised that way too, but my profession just also, I don't know, led me to be more into that.
What is important to know about sleep?
So what's really important to know about sleep is that if you think there's something going on with your sleep and you're not waking up rested and feeling like you can take on the day, there's probably something going on with your sleep. And I personally would advise people to go to myofunctional therapists first because then they can guide you if you need to go dental or ENT first. And it's really important for people to know that it's not normal to snore. It's not normal to grind your teeth. It's not normal to clench. It's not normal to thrash around. It's not normal to have continuous nightmares or really vivid or intense dreams all the time. You can have dreams, but not to the point of your nervous system getting so dysregulated from it. Waking up multiple times a night is also not normal. People have really normalized that. And oh, like he just crawls into bed with us and he wakes up a couple times. Like especially for kids under 5, like think about how many disturbances that is compounding on itself. Like in a week, if a kid wakes up 3 times a night, that's what, 3 times 7, 21, 21 interruptions of sleep. Okay. And then people are wondering why these kids who are already developing these parts of their brain that aren't developed, obviously, like regulation, impulse control, etc., are more like that. And I'm like, well, he's not sleeping, and people think it's really like normal. And the solution always isn't something super cut and dry and super easy. A lot of the times they're going to need dental work later. They're going to need myofunctional therapy later. They're probably going to need OT to regulate them until then. Like our clinic just happens to be an OT clinic that does myofunctional therapy and OT at the same time. So it's like a twofer, right? We get to address both the things. So it's rare in that sense, but it's, in my opinion, almost like necessary because I can't. I mean, I always like the patients I attract now, people know we do myo and stuff, but it's very rare that I see a child without myofunctional like challenges because people know that's what we do, but it's just so prevalent in our society now for so many different reasons related to what their oral history was and what they've been putting in their mouth and the principles of physics of how the mouth forms around whatever pressure source was in there, whether it was a thumb, a pacifier, bottle, or a breast. They all have different outcomes. So,
what is the definition of rested?
great question. The definition of rested is being, I would say, you want to be like in this from a sensory lens is being in an optimal level of arousal where your sensory needs are met and your biological needs are met. And so that means you're sleeping well, you have an appropriate and functioning airway, you don't have nutritional deficits. And I also like to talk about digestion and elimination. So I before like I would say covering those basic biological needs is really important. And then making sure your sensory needs and your nervous system is getting what it wants and needs as well, so that you can be rested in an optimal level of arousal. And that's like the green zone, right? Ready, available to learn, like happy, like ready to go. And of course, life's going to throw you curveballs and you can't always be in the green zone. But it's yeah, but it's also being able to rebound and bounce back and have that neurological agility, is like I like to call it. You have to have that flexibility and agility to manage your day to day and be able to tolerate and have a tolerance to the inconveniences of life that we all deal with, whether it's your blueberries are gross that day and they're sour, or your mom didn't pick the shoes you wanted, or you got a bill that you weren't expecting. It's being able to have the ability to bounce back from that and having that. And I think a lot of people are a lot more neurologically fragile today because they don't sleep well. I think it's a huge silent epidemic in our country.
Please discuss how sensory impacts sleep.
Yeah, so sensory impacts sleep in different ways. So you have to be, like I was saying earlier, you have to be at an optimal level of arousal in order to have appropriate like adaptive responses and motor responses, whether they're motor like based, actual like fine or gross, or I like to say cognitive motor planning or cognitive coordination is the other word I use a lot. So if you're dysregulated all day long, it's going to be really hard for you to downregulate in order to go to sleep. So children with sensory processing challenges, ASD, ADHD, etc., CP, they can baseline be in a state of dysregulation, and that's like their norm. And that norm, the nervous system almost gets so comfortable in that norm that it can't descend into a place to fall asleep. And so their nighttime routine can take a long time. They might not really like start to that unwinding period that a lot of adults have, right? They like, doom scroll on their phone, or they watch TV, or some people have like a nightcap. Like kids don't have essentially all those tools a lot of the time. They have books and they have sleep hygiene and routines and things like that. And that's really, really great. But at the end of the day, if that little nervous system didn't get what it needed, it will have a harder time down regulating to reach those brain waves to relax and get into a place to sleep. And what I see a lot is that some kids have such a unfortunate relationship with sleep because they're not breathing well and they essentially are suffocating in their sleep. They don't want to sleep either. They don't know how to say it, but sleep is so stressful for them that they almost don't want to fall asleep because they know it's stressful, which is very common.
Do you believe in no screens an hour before bed?
Yeah, I do. And I don't I personally will sometimes watch TV before bed too though. So I'm not saying that it's easy, but I do wear blue blocker glasses basically right as soon as I and like really good ones. Viva Rays is a really good company that I love. I love their orange lenses. They're like more the afternoon ones. The red ones are great too, but they're almost like so dark you can't see through them. But I really do think that screens are a huge part of what's happening developmentally too. That kids are really visually overstimulated, and it was like a whole nother conversation with like school stuff. But what happens when kids are watching screens, and adults, and I want to say adults as much, but to an extent, you're being so neurologically stimulated by the content itself that you're thinking about stuff and you're not really giving your brain an opportunity to kind of just relax and not be stimulated. That can be overstimulating in of itself, and then it's harder to descend on that. And then the light in and of itself is really from a sensory perspective very overstimulating. So at the minimum, if you are still, because you have to remember, like, phones especially are a dopamine hit and screens are a dopamine hit. That dopamine addiction is really hard to break, and sometimes people need, it's really hard to break. I'm guilty of it too. Like, I'll reach for my phone. I actually have a rule now where I try every time I go to like grab my phone, I try to look at a plant. I try to find a plant or piece of nature anywhere I'm at. And it's been pretty good actually, but you'll notice how much you like go to it. But it's something that in this day and age, until we find a better balance with technology, and I think as a species, we're evolving with this rapid pace of technology. It's really hard. We're like the transitional, like, ooh, like really figured it out yet, this like balance with it. And so I think people have to give themselves some grace, but using it when they need to, and at the minimum, just wear really good blue blocker glasses. And I love the brand Viva Rays, and keep the content really like slow, like read if you can, do it on a Kindle, things like that, or watch shows that are slow, not super overstimulating. And for kids, watch cartoons. Like if you have a child and you're in your 30s or in your 40s or 50s, whatever, have them watch what you watched when you were younger. Like, no, not Coco Melon, not Paw Patrol. Those shows are so the scenes change every 3 seconds, something's happening. The visual perceptual skills of these children now, when I measure kids and test them, are so high and their motor skills are so low. And it's because they're on screens. So it's like their brains are almost so overdeveloped in the visual department, but the motor isn't because they're being sedentary. And so slowing down the pace of a show, and if you just Google this too really quickly or ChatGPT it, and you can find they'll make recommendations that other OTs have talked about with shows that are much slower pace, like what was it, like Peter Rabbit, like Eureka's Castle, Puppet, Mr. Rogers, like those kinds of things. So sweet, slow puppets, like kids still love that. You just want to keep things really calm if you can.
Can any of these issues develop later in life and or come back?
In terms of like the sleep or the vision part, all of it,
Oh,
all of it. Oh, the orofacial malfunctional stuff,
oh.
all of it. Yeah, I mean, so this is the thing. People always ask me, is he going to grow out of this? Like, is he going to be a sensory seeker his whole life? And the answer is probably. He's Their children are typically like, the thing is that you have to find ways to have outlets for people that are healthy and appropriate for their environment. So I was like a sensory seeker. I was on swings a lot. I was on a trampoline. I had a trampoline when I was a kid. my parents, I'm an only child, so my parents just were able to buy me kind of what I needed. So like I had what was it, a ball as a chair like by third grade, and I just kind of would adapt and do it. And but I was really athletic, so I played a lot of sports and got sensory input that way. And the thing is that if you know your child is like a sensory seeker, what you want to do is create an environment in which that they can thrive by being a sensory seeker. Because if they're not like, if you don't give them an outlet, like they're going to find one, whether it's mouthing their clothing, whether it's biting their nails, whether it's jumping on your couch, whether it's leaning on peers or accidentally shoving peers, or you can like put them in gymnastics, or you can put them in jujitsu, or you can put them in I don't know, football or hockey or something where those types of movements and that type of input is actually structured and like facilitated in a way that can help them function with whatever sensory profile they have. And as adults, a lot of people don't realize it, but like CrossFit people, like they're sensory seekers. They like picking heavy stuff up.
Mm.
Do you know what I mean? Like if there's a guy that you're traveling with and like a group of friends and he's happy to carry all your luggage, like I have a friend like that, he's a sensory seeker. Like they find their ways, right? And so you have to just kind of help people realize what their sensory profile is, whether it's sensory seekers, avoiders, or people in between with different sensory systems, and help them with that. And I think some kids, though, I will say, have come into my clinic and they present very much one way in a sensory profile, but what was happening, it was actually an airway disorder. And these children were presenting as ADHD, very hyperactive, sensory seeking, and there was an underlying airway issue. And once that was resolved from an ENT visit or tonsils and adenoids, and or with a combination of orthodontics, usually that is part of it, or dental expansion, they don't really have that anymore. And that's something that has been very eye-opening to me. And then I have my kids who definitely still have their ADHD symptoms or the diagnoses, and but the severity of their sensory seeking behaviors goes down tremendously once we open up the airway, get them expanded, and get them breathing and sleeping better. That
Please
really,
talk about how releases don't automatically fix everything.
yeah. So the tongue tie releases in the realm of airway is a whole thing. It's a hot topic. There's been many articles written about tongue tie releases, and you always want to check like who's writing what, et cetera. And I personally feel that tongue tie releases are something that a lot of people over romanticize, and they think it's going to solve all the problems, because you have to remember medical professionals are subjected to putting all this medical information into 60-second clips or 90-second clips on Instagram to educate you, which is not the way that we were educated. It took us years to get this information, and then we have to kind of try to like digest it and back to people, and it's kind of impossible. And so I think there's been this huge informational overload with people, and I think there are some people also who do like present it in a way that isn't necessarily always presented the best way. It's still a procedure. I think tongue ties are part of the story. I don't think they're always the solution and end all be all for everybody. I think a lot of people see a lot of relief from them. I personally had like laser treatment for my tongue tie. I haven't had a full release yet, but I have an anterior and a posterior tongue tie. I'm a really good case study. My tongue before could barely lift. It was like that. And then you would see all of my like platysmal bands, and I was just like straining so much. So I have a lot of less tension here now from my laser treatments. But tongue ties, I think in infancy, and the earlier you do them, if it's really an obvious issue, can help a lot really quickly. You have to remember, it's not just releasing the tongue tie, though, it's retraining how that tongue needs to function, because that tongue that was tied never really had the chance to function appropriately because it was so tied. And so it learned how to drive essentially inappropriately, and it needs to go back to driver's ed once it gets a new car. Does that make sense?
How do you support clients post-operation?
Yeah. So typically when a tongue tie is on the table, we typically do sessions before too. So you want to make sure that they can do their post-op exercises, especially kids, because if they can't do post-op exercises before a procedure, they're not going to really be able or want to do it with a wound in their mouth. nobody would. It's not really that fun because people need to remember there's so many nerves in your mouth compared to the rest of your body. Like other than your hands and like your privates, there's not that many nerve collections like there are here. And so the level of pain people can feel is quite intense. And that's another thing. Like I think people are like, oh, it doesn't even hurt. And like all this, and I'm like, no, like I've had a lot of people tell me like tongue tie releases can hurt. Like, and I think also I have a very sensitive population, like my sensory kids, like they don't even like toothbrushing. So like we don't jump into a tongue tie release with them, right? So because that's a lot for them. But how I support people with surgery is I basically do exercises with them before to make sure that they can complete at the bare minimum their post-op exercises and they understand the anatomy of my lips, my tongue, where is the spot, where should my tongue go? Is my nose on? Can I breathe through my nose, etc. How does my swallow work, etc. And then we work on those things after release and really minimizing habits or things that can produce negative outcomes with a release. So if we've got a kid who thumb sucks, like I'm always really hesitant to release a child who's currently thumb sucking because if they continue to thumb suck, they're just pushing down the tongue and shortening the wound that was created to create more range. And that's usually not a really great factor that you want post-operatively.
What are other options for treatment?
For tongue tie release,
Oh.
all of it. There's a lot. How much time do you have? There's a lot of things to cover. So there's really good lasers out there now, like that I've seen great outcomes with that not a lot of people are familiar with. Like baby lace is a great laser that helps with the fascial tissue basically glide a lot better. And it makes just everything in the fascia just really, for lack of better words, buttery and soft. So these like these mouths that are just really tight, or these tongues, or these cheeks, or these lips are like, it's tightness. It just like lets things get like movable and like just like buttery. I don't know how else to put it. Then we also have other lasers like sleep lace that can actually, what I've seen do is like the soft palate will be kind of hanging down here, kind of like a Mallampati score of like a 4, right? Where the actual flashlight, the actual soft palate is dropped down and low like this, right? And so they have lasers that will like go like here and it'll like open it up. And that would, what it does is it like, instead of it falling down and like what that's what's making sounds when you're snoring a lot of the time, it goes and it opens it and makes it taut and tight and it opens up the airway where you would see more of an airway. And like, you see how my airway is open? You can see it. You can see my uvula. Okay. I can't even really like do it now, but like I can't because that's not how it is anymore. But when people have a saggy uvula, essentially, the laser will open that up. And that would take like 6 months, maybe in therapy, 3 months in therapy with a kid. Adults way faster because they listen. Kids is just the back of the tongue. They have to understand it. It takes time, etc. They have to, the back of your tongue holds all that up. And so these lasers are amazing. And then orthodontic intervention is really important too. And then sometimes you just need to do the release too, but it's also the order in which you do it. If you have a really narrow palate, should you release a tongue first? You might want to get expanded first so the tongue has somewhere to go. You know, some cases that you might make it, barely make it. It's very case by case basis.
How do you do these exercises with sensory avoidance?
So I always start with the desensitization protocol. So that's one of the things that we kind of like specialize in, is a lot of people will say like, oh, we don't do myo with kids under 4 and things like that. Like we do myo with like, you know, in our, like my own version of it and with my kids who are sensory avoiders and things like that. And you have to basically over time desensitize the mouth and let those kids get comfortable with their mouth being stimulated and activated. Because if you can't get in there to activate things, then they're not going to do it themselves. Because then it's, you know, like a lot of people will avoid things that are uncomfortable, right? And kids are no different. They're like a raw little nervous system. And when your tongue isn't suctioned to the roof of your mouth, your palate gets really sensitive because your tongue is there to desensitize it. So gag reflexes will get stuck in all sorts of different places. You have a gag, yeah. You have a sense of gag reflex? Yeah. And it's usually due to tongue position or swallowing. So like my tongue thrusters, sometimes like I see a gag reflex that gets stuck like on the interior, like 1/3 part of the tongue. And a lot of times it's because nothing's touching there. And so the gag reflex will just, I notice, get stuck there, or it will move around, but you want it further back because then what happens is it becomes like almost hyperactive and triggered too easily, right? And then it gets in and interrupts with feeding. And so it's something that the desensitization process, you can't stimulate something if it's super sensitive. You have to work with those nerves.
How do we breathe properly?
So you breathe properly by having your tongue suction to the roof of your mouth and your lips closed and through your nose. Inhaling and exhale through your nose quietly.
Thank you, Dr. Mitchell, for doing this with me. It was great to have you on.
No, it was great.
Please share this talk show with your family, friends, and colleagues. Everyone watching, don't forget to like, follow, subscribe, and share on Facebook, Instagram, and YouTube.